Dr. Manu Sharma is there. Dr. Manu Sharma will be speaking on immediate sequential bilateral vitreoretinal surgery for management of ROP.
Good morning, everyone. I'm feeling grateful for this opportunity. My topic is immediate sequential bilateral vitreoretinal surgery for management of retinopathy of prematurity. Immediate sequential bilateral vitreoretinal surgery is defined as vitreoretinal surgery in both eyes during the same anesthesia session. It is an enormous need in the era of more advancement in neonatal care, more of surviving of premature babies, and lead to more incidence of retinopathy of prematurity. Although there is an awareness of ROP, but still it's lacking, which lead to more of ROP cases in stage 4 and stage 5 presenting to us, which are not manageable with anti-VEGFs and lasers alone. So here comes the need of bilateral or need of surgery in these patients. So why bilateral simultaneous? Because it is a bilateral disease, symmetrical disease, and progressive. And there is a risk of anesthesia, and these babies are small, sick, premature, also associated with comorbidities like RDS, BPD. So, and the risk of re-anesthesia for the second surgery is difficult and undesirable. So it also leads to delayed surgical intervention and the poor outcome, as disease is bilateral symmetrical and it is progressive. And there are financial challenges also. So single session surgery can address all these issues and lead to good outcome. So our purpose is to study the efficacy, safety, anatomical outcome of bilateral sequential vitreoretinal surgery in advanced ROP. So it's a retrospective interventional study conducted in tertiary eye care center. We include the cases of 4A, 4B, and the 5 open funnel ROP. We exclude the closed funnel RD patients and 5C with anterior segment malformations. The electronic medical record system was used to get the data, and the surgeries were performed by the two surgeons, and the maximum follow-up 3 months were included. So we found 55 eyes of 28 babies with mean birth weight of 1,188 grams with mean period of gestation of 30 weeks. 68 were males, 32 were females. At the presentation, the stage 4A was seen in 16 eyes, stage 4 in 36 eyes, and stage 5A in 2 eyes. One had vitreous hemorrhage. So lens-sparing vitrectomy was done in 50 eyes, and lensectomy vitrectomy was done in 5 eyes. Laser photocoagulation was done in all eyes except stage 5, and preoperative ranibizumab biosimilar was given in 21 eyes. So outcome, we defined anatomical success as complete success when the fovea was attached and there was no peripheral traction. And in incomplete success, we labeled incomplete success as when the fovea was attached and there is only mild peripheral traction, but no traction at the fovea and the macula. And failure, we defined when there is some traction at the macular area or fovea. We have low threshold for the failure. I think we kept the low threshold for the failure. We even labeled when there is some traction at the macular area, we labeled it as a failure. In ocular complication, we found hypotony in 2 eyes, choroidals in 1, loose blood in 7 eyes, and no endophthalmitis was noticed in any eyes, which was the main concern in bilateral vitreoretinal surgery. In systemic complications, only 2 babies had anesthesia-related complications, and 1 baby had, we have to abandon the second eye surgery because it was not, the baby was not maintaining saturation, and 1 baby had apnea, but it was after the surgery, and he was kept under monitoring and recovered. This outcome, we found a good anatomical outcome. The fovea is attached and there is no residual traction. So it is a blinding disease of low birth weight babies. Timely management lead to better anatomical and functional outcome. Risk of GA-related morbidity is high, but with a good anesthesia team, it can be manageable. And although there is a risk of endophthalmitis, but it can be addressed because during intraoperative period, we manage the both eyes as a single individual eyes. There is a redraping and trolley is remade and the surgical team scrub and every precaution is taken during surgery and there is no risk of endophthalmitis, or we have not reported a single case of endophthalmitis in our series. Although there are ethical issues which can be addressed and the patient we can minimize the GA-related morbidity by taking extra precautions. So to conclude, BVS is a safe and feasible option with good anesthetic care And as the disease is bilateral, symmetrical, and progressive, so it can be a feasible option. And well-informed consent mentioning risk of anesthesia and bilateral endophthalmitis must be taken to avoid medical legal consequences. Thank you.
So you wanted to do bilateral cases. So the idea was basically that you want to deal with both the eyes very
Yes.
quickly in the same sitting.
Yes, sir.
So why did you include stage 5 ROP cases in this? I mean, there's no urgency.
So stage 5 cases, only the stage 5A cases, which we thought they can be managed when the funnel is open. We can approach.
So the early stage 5.
Yes, sir, early
going
stage
into
5. Yes,
closing
sir.
funnel.
But I think it's unethical doing sequential surgery both eyes together, same sitting.
No, sir, I don't think so. It is unethical if patient attendants give consent and we have a good anesthesia backup.
Patients
And
will give consent, patients, they are in that kind of space, they would give consent.
Sir,
It
I
doesn't
think-
mean that just because consent is there, we must go ahead with everything.
no, sir, I think the only concern we have is the risk of endophthalmitis, which can be addressed because we prepare both eyes as two separate cases. First, we do the one eye surgery, then even we ask for 2 packs from the patient. Under GSSK scheme, we have 2 packs, 27 or 25 gauge, whatever. So everything is prepared as a separate case for both
So
eyes.
despite all precautions,
Yes,
you
sir.
are saying there can be endophthalmitis, that possibility is there, nobody can rule
Yes,
out
sir,
the
there
possibility
is
of
a-
endophthalmitis.
Yeah,
So
but
I think that bilateral surgery in a young child, I have my concern.
sir, there are only,
Dr. Manu,
yes, sir.
it is good that you have presented this in the conference, but it is practical advice not to do it practically, because even if a single case is there in lifetime, nobody is going to spare you.
Yeah.
What would be the socioeconomic status of the patients? That would also really make a lot of difference on the post-op care that is offered by the parents. Once you've done the surgery, you've taken all precautions during the surgery, but what about after?
Sir, what is your take on this, like, since we're having a discussion on this ethical issue? Because, sir, in pediatric cataracts also, outside India, everybody is doing bilateral sequential.
Yeah.
Yes, ma'am.
The only thing is, only common aspect of doing a bilateral sequential is the OT setup. Rest of the things you have taken care of. It's the
So
OT
we also do
and bilateral
bilateral.
cataracts.
We also do bilateral simultaneous because stage 4 is rapidly progressing, and the children are very sick and are
Ma'am,
very high risk for
actually-
GA. So doing simultaneous is recommended in stage 4A, where it's because child might become very sick after that, and the second eye might go blind. So earlier we also used to do sequential, but now we also do bilateral simultaneous in stage 4. Where it's just a very small window,
Yeah.
and the
It's
child
very
might get
small.
very bad in a 1 week time if you delay the surgery. And
If
two
we
GA
delay,
sessions.
that lead to blindness in the other eye, because,
We should have clarity about the indications, I think, that's
Yes.
more
Yeah.
important.
yeah.
Thank you.
Do you consider this factor, like do you check the socioeconomic status of the?
No, we don't.
Ma'am, they are very,
And that is usually one of the intra problems.
When I have had a few cases with post-op, they went and.
Very rare, very rare.
Yeah.
ma'am, we prescribe both eyes different drops and everything different.
Yeah, actually the
Different
take is
set of
that
drops
we,
for
we have
both
to see
eyes.
the pros and cons. Where if you are going towards a worsening of the disease in few days, means we can go ahead.
Yes,
na?
ma'am.
Otherwise, because we can take precaution per-operatively, but post-operatively, if the parents, they don't take care, the child will go blind.
Actually, we have population which is quite poor. They are
Yeah,
not able to
the
access
post-op
supply.
care is also
The
very
follow-up
important.
may not be there. So I think we shouldn't compare everything with what's happening in West. It's a different kind of scenario with us. If somebody comes to RP center, he may not be able to come back. They go back to 500 kilometers. And they're not able to return. I think that aspect is important to keep in mind in our setting. Thank you.
Thank you.